Okay, that's great. Okay, so I'm Antonio. I'm a consultant neuropsychiatrist. I used to work in Merseycare, obviously trained in Merseycare as well in Liverpool. Uh, in the background, obviously, I've more recently trained in neuropsychiatry to become a consultant neuropsychiatrist. But I have previous experience in substance misuse from South Asia, and I worked in the United Nations as a substance misuse psychiatrist. My previous job in Liverpool was in substance misuse around Liverpool and Southport. So I've got obviously a background of substance misuse, but currently working as a neuropsychiatrist at the Walton Center in Liverpool, which is a neuroscience center. So that's a bit of an introduction about me. Let me start with what we want to do today. So I've got around 45 minutes is what I'm trying to keep for myself. So let's look at what we can cover during this time. It's a large topic, substance misuse, because there's so many drugs, drug of abuse. And I mean, obviously in this lecture, you won't be able to cover that. What I have done is just try to concise everything so we can just focus on exam related and obviously clinical practice related information around substance misuse. And I've tried to sort of bring them all together into certain concepts and terms which can be applied for all the substances, including alcohol. Okay, so if I can manage to cover these points, I think I've achieved what I want to achieve in the 45 minutes today. Okay, so basically understanding terms around substance abuse, yeah. Then look at a bit about history taking in a substance misuse clinic or a ward. We look at terms like misuse, abuse, harmful use. And then we touch upon a thing called as motivation to change, or the cycle of change. We also look at medical, psychological, social complications of substance misuse. We touch on some of the common one, and the common one will be obviously top of the list will be alcohol, but you'll also have opioids like heroin and cocaine. But I'll touch on some of the others, but I'll let you all read through because I've got some slides of other drug of abuse. And then I'll give a sort of a common theme around all these substances so that you can understand them in your clinical practice. How they can be categorized when they present to you in a A&E setup or the ward setup, and how you could differentiate. And then we look at treatment options, and then obviously the concept of harm reduction and relapse prevention. Okay, so I hope I can cover all that. You might find me rushing through some of the slides, but what I want to do is I'll focus on things which need focus today, and probably exam related and also clinical practice related. Okay. So I won't, look at what you are thinking, but it's a common thing, isn't it? And obviously all of you all have encountered, patients, even probably people close to you with the problems with substances. The most commonest one obviously is alcohol. Okay, so let's go straight to the term which we need to clarify first of all, which is called dependence. Okay, dependence is a diagnosis. So if you're looking at any substance dependence, these are the things that you need to look at. In previous lectures around this, I tried to use alphabets which can identify these different criteria that help you make the diagnosis of dependence. I mean, you could use them if you want. Or you could make a mnemonic to help you remember, okay, what you need is 3 or more of these. Okay, so the first one is obviously a compulsion. A compulsion is something like having a strong desire that I need to take that substance. And it wasn't there before. It's never been there before in that person's life. And all of a sudden, now he's developed that strong desire for that particular substance. So that's a compulsion with a C, okay? And then that compulsion goes a little bit further, and then he loses control over his behavior. So loss of control is a second criteria. You have 2 types of withdrawal. One is the physical withdrawal, and we're going to look at different withdrawal symptoms that can happen with different substances. And then a psychological sort of dependence, so much so that all other pleasures and interest and responsibilities in lives are lost. And I've used the letter S for that. And I'm going to tell you why I use the letter S instead of P. And then comes tolerance, which is something that we as medical students and doctors, we know about tolerance with other medications. How, we start with a small dose and then it slowly increases to give you that right effect, but sometimes loses its effect after some time. So that's tolerance with a T. And then finally, using despite harm, which is harmful use. So we're looking at 6 criteria. You need 3 or more of these to make a diagnosis of dependence. So yeah, so I was telling you about, let's go back. So the S from preoccupation with use is also called salience. And sometimes this does come in the exams. Obtaining and using the substance takes over, other interests and pursuits are neglected. Yeah, so it's basically psychological dependence is the word which I sometimes use, but the correct word is salience. Okay, so and the other word they sometimes use is primacy, but salience is something that they commonly use, and also question, in exams, this is the word that they're going to use. Okay, tolerance, we've covered that. So it's increased dose of the substance is required to achieve the original effect. Yeah, so this contributes to escalation of use, carry on using, and also higher doses are required to achieve the same, what people who get addicted will call as a high. Okay, so that's tolerance. So another term that does come in exams and used quite closely with substance misuse, and was described in the initial criteria for dependence, but was taken away. So there were total 7 criteria. It's now left with only 6. Is what is defined as narrowing of repertoire. And I don't know why they've taken it away, but it's something you do see in addiction behavior, but not probably as common in someone like a social drinker. Yeah. So you might find people going and having binge drinking sessions very, very regularly and could be dependent, yeah, but not have a loss of variation in the type of drinks that they have. Okay, but I mean, it is part of substance misuse, and you would see that over time the person becomes so addicted to that substance that they don't want to make any changes to that particular brand. Like, for example, I mean, if it's a spirit, then it would be only one brand of that spirit. And it probably falls in that bracket where they're trying to say, I don't want to lose that particular high, or you become so psychological dependent that you associate that image or the bottle or the glass with that addiction. So it's a process. It's a process of environmental cues. And this is something that probably prevents the treatment as well. And that's why you need a lot of work during relapse prevention, because there's a sort of a process from a neurological point of view where there are cues in the environment, and this probably is one of them. But anyway, it's not part of the criteria, but it's something that we do talk about and can be questioned in the exams as well. Okay. The next term that we commonly use is intoxication. Now, intoxication is obviously there are few things that happen in with the substance. Yeah. So the level of conscious awareness is reduced or heightened. Yeah. So there could be 2 things: reduced or heightened. Yeah. The thinking process could change. Yeah. So either making an anxious thinking become relaxed, for example, in benzodiazepine or alcohol. Perception can change, so you don't want to see the normal shattered house you're living in, and you suddenly see different lights or a different perceptual feeling. Your emotions change and your behavior change. So these are things that are required to call a substance of abuse or a psychoactive substance. Okay, there's one more thing you need to call something a substance of abuse. The intoxicant effect should not last forever. So no person will like intoxication that will last. Although they will say, "I like to be high forever," it needs to come down so that then they can achieve that element of having had a reward and want to seek that reward again. So it should resolve with time. Okay. And obviously different substances have different symptoms of intoxication. Okay, the next term is withdrawal, and this is, we are talking about withdrawal physically. Okay, so physical withdrawal signs. Something which I've always mentioned to students is uh, try to think about them as a reverse symptoms of intoxication. So if you're feeling relaxed when you're intoxicated, you will feel anxious when you're withdrawing. Yeah. If it's helped you to sleep, then you'll have insomnia as a sign of withdrawal. Okay, so you could use some of them to help you with your exams questions and things like that, or even when you see a patient with clinical presentation, you usually see the opposite, okay, of so even with the pinpoint pupils, which you'll see in intoxication of opioids, you'll see the reversal when they are in withdrawal. So you'll see quite dilated pupils, okay. So clear evidence of recent cessation or reduction of use. Yeah, so there's obviously a stop in the use of that substance. And then there is a range of signs and symptoms. And then classically, when you reinstall that substance, these withdrawal symptoms should go away. I hope that's clear. I can't, I mean, obviously see you also. I'm just talking to myself, but I hope I'm going at a pace which you can catch. But obviously, I mean, we'll at the end, I'll take questions as well. And we can go through the slides at that time as well if you have any questions. Okay, next terminology, harmful use. You remember harmful use? Harmful use was the 6th criteria on that list of dependence. Yeah, harmful use. It's amazing how this term comes into that criteria, because Oxford Textbook of Medicine does point out about how medical doctors tend to get addicted to substances. And although they know the intensity of harm these substances cause, they don't realize it when they get into that mode of dependence. Yeah, so harmful use is basically being aware how much the substance will damage their body, and they still continue to use it. Okay, so pattern of use that is persisted at least at least for a month or lasts repeatedly over the 12 months period. Yeah, so this is a term you would use for coming to a diagnosis of dependence, so harmful use. Okay, there's obviously there's an aspect here which I sometimes question clinically. If a patient that comes to you doesn't know, like if a medic is addicted, it's different, isn't it? Or if a clinician who has been working or knows about substance damage and things like that, or seen in their are aware about the harm, then you might be justified to say there is harm. So sometimes just educating a patient that comes to my clinic, just telling them about how much it can cause damage itself can help them reduce their substance use. So in that case, are we talking about dependence? So basically, to call it harmful use, you need to you need to be certain the person you're talking to knows about the harm. Yeah, so just assuming that everybody should know that there is harm is not right, because some people grow up in families who have been always using some form of substance, and then they don't think that it's been harmful because they've not had complications, or they've lived life with that substance. So evidence, they have to see that clear evidence of physical or psychological harm, either to themselves or to the people dependent on them, to then call it harmful use. So that criteria is knowing the harm and then still using the substance. Okay, so that's your harmful use. And then abstinence is staying away from the substance. So what we're covering is also terminologies that are closely used with substance misuse. Okay. And reinstallment is basically relapse. Okay. Detoxification is the opposite of intoxication. So detoxification, you're removing a toxin out of the body. Yeah. Many a times it is medically assisted, especially when you're at a higher level of your drug use or substance use. And if there is complication, could you detoxify without medical assistance? Yes, you could. There's a term classically used called as cold turkey in opioid addicts, but they do use the term in alcohol dependent patients as well. So you can do it without the help of medical. But obviously, at a certain level of intoxication, you will need some medical support. Otherwise, you can die, and death is a risk. Yeah, that during withdrawal is a risk. Yeah. I mean, I've said to some of my patients who have been opioid dependent on opioid that the withdrawal from opioids will never kill you. And obviously, I've never seen someone dying of that. It's painful withdrawal, but they'll not die of that. The consequence or as a result of that pain that they try to engage in various risk behavior is what causes death rather than opioid. But alcohol is very risky. Alcohol is very risky when a person is withdrawing from alcohol, I mean. So when they're withdrawing from alcohol, they can have various complications. And we'll look at it. There's a slide on what is called as delirium tremors. But yeah, opioid does not cause sort of death as a risk, but obviously the cold turkey or the withdrawal state is quite painful. Okay, so that's detoxification. Okay, so stages of change. Yeah, stages of change was defined by, so don't forget the names is what I put a slide separately because we always forget. This comes for exam. So these are the two people who actually describe the stages of change. Stages of change is not specific only to substance misuse. People use it in motivational interviewing, like stage coaches on performing on stage and things like that to make changes in people's behavior. So you could apply this to any form of change in behavior. For example, just getting you motivated to go to the gym. Yeah, so you could apply these stages to see how you can change. So it is a process of change basically. Okay, so pre-contemplation is when the person thinks just like that harmful use which I was talking about, where they don't know about the harm, so they're not bothered about thinking about stopping that substance. So that's pre-contemplation. So person feels there's no problem, though others recognize it. So it's a doctor sitting in the clinic who's telling me all about stopping to stop smoking, but he doesn't think, he knows his father, he knows his grandfather, they smoked all their life, so he doesn't think it's harmful. But he's now thinking, why is the doctor telling me? So there is an aspect where I'm triggering something in his head. Yeah, so that's a pre-contemplation, but he doesn't want to make a change. So that's pre-contemplation. Contemplation is, he's thought about it now, and he thinks, yes, there is some pros and cons of stopping. So he thinks, previously I was able to run, and because I'm smoking, I can't run anymore, or I can't do the amount which I used to do before. So contemplation. So he's thinking about it. Decision is when he starts making preparation for it, or he makes a decision. He sets a date, he sets a goal. He says, my next birthday is the day when I'm going to pack up. Basically, I'm going to have no more cigarettes. So that's decision. Action is on that day, he actually stops, and then stays away from it is maintenance. And then finally, one day he meets a group of his old friends and he has a cigarette, and that's the start back. So it's a cycle. Okay, so it's a cycle of change. Okay, and then he starts back again at the point of either pre-contemplation or contemplation, and the cycle goes on. At some point, obviously, in maintenance, you leave that cycle. Okay. So that's your stages of change. Again, something that they'll ask in the exams. So it's something that you need to be aware about. Don't forget the names. Okay, patient interview. Yeah. What are different things that you want to know? Yeah. Obviously, starting with the age. Yeah, age at when they started these substance misuse. What type? What type of substance did they start with? You might have heard the term cannabis is a gateway to drug addiction. So was it cannabis? Was it alcohol? What was it? Yeah, how often were you using, and how has that changed? What was your route of administration? So most of them start off will be oral, as in consumption orally. And then it slowly changes where they start thinking, okay, I'm not getting as much high from an oral use, for example, substances that can be injected. So they tend to inject, like opioids can be injected. Yeah. And then history of overdoses. Yeah. History of abstinence. Have you ever tried to abstain? And this is very important. And you know why it is important is obviously because they've gone into that cycle of change to come to the place where they had thought about stopping, and they've tried to stop. The chances of them being successful is much higher if they've tried it in the past. Okay, so abstinence and relapse triggers are very important. Complications if they've had, because there's chances that this complication will happen again. So if I had a patient on my ward, I mean, I don't work in that ward anymore, but obviously I used to run that detox unit for opioids and alcohol particularly. History of seizures is something that I would be worried about in patients, and I would sometimes think about, prophylactic anti-epileptics as well to prevent, a patient from going into seizures when he's on the ward. So yeah, medical complication history is very important. Okay, so that doesn't finish there because there's another slide. So uncover the relation of substance abuse with the presenting complaints, and then look at the specific syndrome. Okay, so we covered all these syndrome. Psychotic disorder. Okay, when I'm sitting and doing the rounds, I will obviously, because it's a specialty under psychiatry, we have to cover areas which are which can happen, which are associated. For example, psychotic disorder that can happen with substance misuse, and amnesic syndrome. Yeah, so amnesic syndrome, like dementia, can happen as well as short-term memory loss with substance misuse. And you know that we tend to use a medication or vitamin called as thiamine that helps build that cognitive levels back once they stop using alcohol and continue taking nutritional supplements. So amnesic syndrome, both temporary as well as permanent. And then consequences, yeah. And then determine level of patient's more. So at the end of the history taking, I would expect, to cover and to understand what level of change, what stage of change my patient is in, so that, obviously I would, if they're in pre-contemplation, I won't lose that opportunity to start motivating them. So I would start instilling that idea about harm, so that then, the next time they've come back to me, and I have seen my patients coming back for years, and it's a revolving door. So obviously, I mean, I want to see that change. So I know what are the, exact things that help that person to make that change. And harm is a very, very important thing. So the nurses on the ward used to always say that I tend to print out the LFT reports of patient and place it in front of them, and then show them the comparison numbers. Most commonly, it's the GGT, which used to be massively high in the thousands. And then I used to demonstrate to them that how these changes can happen at the end of their admission. So, I mean, classical and very effective way of motivating someone to, make a change. So that's what I mean by harmful use. If you're not aware about the harm, you won't be classed as harmful use, would you? So, yeah, so it's useful to show that harm, the effect of this on their physical health, or, psychological or social or employment. And it does make a difference to their motivation levels. Okay. And then you obviously signpost them. You signpost them when they're leaving from there. One important message, obviously, for a heroin addict is don't start back at the dose you stopped, because your tolerance has come down. And there's a risk that you will overdose if you start on the same dose. So that's classical with opioids. What can happen with any other substance as well. So don't start at the dose you stopped. So if you were using around 6 bags when you came into the center to get detox, now you're clean, the substance has left your body, you lost the tolerance. If you go back on the 6 bags, you're going to die. And yes, it has happened in the past. I used to have a key worker in the job which I used to do with the UN in South Asia. This was in Colombo. He was very active for many years, been away from opioids. And one day they told me that he's not come to work, and we tried to hunt him, and we found him dead because he relapsed. And he's a person who worked with people advising about overdose. And I'm not sure what happened, whether it was, coexisting mental health problems that went into that stage where he used it as a form of suicide. But yes, he had an OD or overdose. So overdose can happen. Okay, and it's something that we need to mention at the end of the interview. Okay, and that's what brings us to the dual diagnosis concept. Okay, Declan earlier was telling you about emotionally unstable personality, something which I tell patients with emotionally unstable personality, that the emotion is unstable. Yeah, to make you have to avoid anything that makes it further unstable. So substance misuse is something that definitely makes it unstable. Yeah, and it is closely associated with UPD or other personalities as well. So there is a close association between mental illness and substance misuse, either as a cause or it's vice versa. So, or they can just occur together because of various reasons. So yes, dual diagnosis is mental illness and comorbid substance misuse problems occurring together. Okay, I have a nice slide. I think it's next, where it shows you the association between mental illness and substance misuse. Let me just see if it's, yeah, it's here. So alcohol or drug use, yeah, can directly cause mental health problems. So you know that people can have alcohol-related psychosis, yeah, and yeah, depression is very common in people who drink alcohol. But then mental illness by itself can cause, a person to go into drugs and alcohol. So that's a direct causal hypothesis. But there's an indirect causal hypothesis that while they've been involved in substance misuse, there have been times when they had mental illness, but mental illness is not the predominant problem over here. The predominant problem is the alcohol or the substance. And once they stop that substance, the mental illness also stops on its own. So it doesn't probably need treatment. Yeah, does it happen? Yes, it does happen. They come to my ward, they are completely psychotic. I put them on the titration dose to withdraw them off the drug, and they don't have the psychosis. So it can happen. So just stopping the substance itself can make a difference. Yeah. Similarly, mental illness is happening there, and then in the background there's substance misuse that is going on for years without causing much problem to the mental health. Yeah. Sometimes my colleagues in general psychiatry will say, do something about this substance. It's always making a difference to how he is complying with his medication. So it does affect to a certain extent, but it's the predominant problem is the mental health condition. So this is called indirect causal hypothesis. And then the third hypothesis is a common factor hypothesis, where they're saying, for example, low socioeconomical background or childhood trauma, both of these, that being the cause for both alcohol and drug use and mental illness. So a common factor resulting in both the illnesses. But what we are looking at today is dual diagnosis. There is a close association between mental illness and substance misuse. And that's probably the reason why psychiatrists are the ones who are dealing with this. And it's something that, you would be always seeking help from the psychiatrist, because there's a close association between the two. Okay. The rate, 22 to 44% of psychiatry inpatients have problematic drug or alcohol use, higher rate in urban and inner city areas. Yeah, so these two figures, I think you might have to remember, because I think they do ask this question about what is the incidence, and this is a general one. There are different surveys that were done, but 22 to 44% for inpatient. I'm not sure about the outpatient, because this was the second one which said 36% in the outpatient, and that's, I think, something that we have finally agreed, saying that if it's asked for the exam, you're going for this average rather than the low average or the high average. Okay, so inpatient and outpatient. Okay, so that's your dual diagnosis. I'm not sure about this. It keeps changing, isn't it? But obviously, safe level is something. Okay, so this is the most up to date: 2 to 3 units per day or 14 units per week. Okay, so this can be asked as well. So it's important to remember this. I don't think it's changed since the last time when it was updated by the chief medical officer. So if they ask you, sorry, in the exam, this is the correct number. Yeah, I'm going to leave that, but I'm just going to point out occupation doctors are high risk of substance misuse, particularly alcohol, male more than female. Yeah, we looked at this, isn't it? So obviously, I was telling you about intoxication. The symptoms, signs of intoxication is the opposite, which happens in withdrawal. So you could see some of that common things, isn't it? So like insomnia there in withdrawal, and there's sedation when you are intoxicated, and you feel anxious when you're withdrawing, while you feel relaxed when you're intoxicated. So it's sort of an opposite type of thing. Obviously, when you
when the level of alcohol use increases, you can have slurred speech, ataxia, um, flushed face, confusion, and sometimes you can lead, people can have death due to alcohol use. Just alcohol use, intoxication to a level that it can kill them. So alcohol can kill at a high dose. So that's the tail end of that intoxication. Okay. And obviously withdrawal, as I was telling you, alcohol withdrawal is scary, is dangerous. It can cause death. So delirium tremens is one of the complications of alcohol withdrawal. Chances of death rising from 5 to 20% when someone is in delirium tremens. So you definitely need medical support to be there around when you're dealing with someone who's got alcohol withdrawal. Okay. I'm not going to go through the symptoms. Okay, I'm going to leave this with you, okay, to just sort of revise just before exams as well. Okay. I'll leave this one as well because this is something you will be alert and aware about. Not just you, everybody will know about it. I'm thinking it's liver, cirrhosis, hepatitis. I mentioned about dementia, didn't I? So alcohol causes alcohol dementia. So I used to run a sort of a service called alcohol-related brain injury, and I used to do some form of work with them to assess what level of cognitive loss they've had due to alcohol use. So what I've always felt is if you stop alcohol, it is a temporary on most occasions. Okay, almost 80% of the time, this is temporary amnesia. Okay, but there is a 20% chances that 20% of people will go into permanent dementia, and one of them is Korsakoff psychosis, which we're going to cover next. Yeah, so you might have heard about it. Head injuries are very common. So I mean, now I'm working in the Walton Neuroscience Center. I mean, obviously in UK, the second largest reason for head injury is falls, and most of the time the falls is associated when they've had a few drinks. So head injury is a big one. Fetal alcohol syndrome is another thing. Again, neurodevelopmental for the infant. Yeah, so substance can increase the risk of suicide. Declan was talking about it earlier. Yeah, I mentioned about alcohol causing psychosis. There's something called as morbid jealousy, and I'm not sure if you've ever come across, but it's something that you can read about after, later today. You can just read a little. It's interesting, but it does happen very commonly with alcohol. It's called morbid jealousy. I mean, it's a homework for you. Look at what is the other name for morbid jealousy, and it happens in alcohol-dependent patients. Okay, it's a psychosis. It's a delusional disorder, morbid jealousy. Okay, I'll leave you with that one. Yeah, don't need to talk about this because everyone knows about it. Yeah, I'll give you these slides, isn't it? So you can go through them. Okay, so let's cover the ones which we need to cover. Alcohol works on the GABA receptors is something that you must be aware about. Yeah. I need something which can work on the GABA receptors to take them off the alcohol. And obviously the only one which I classically use is benzodiazepine. Yeah. And the most classical one of that is chlordiazepoxide or Librium. Yeah. So we tend to use Librium very, very commonly, except for patients who've got liver problem or even liver cirrhosis. I use what is called as oxazepam. I mean, the dosage, I think, is almost equivalent doses. Yeah, so we look at units and then unit of alcohol that they use, and then we substitute that with the amount of benzodiazepine. Yeah, so on a day one, someone who's been drinking almost a bottle or two bottles of vodka, I would be giving them up to around 40 milligrams 4 times a day. That is 160 milligrams of chlordiazepoxide, an additional 80 milligrams if they have withdrawal symptoms. So I'm looking at a massive dose on day one of detoxification. I mean, services, especially in mental health, so much, cutbacks on funding and things like that. So now what we are left with are only those complex ones. People who drink maybe half a bottle every day are not the ones we see in the inpatient. They are now being asked to be managed in the community alone by community detox prescription. I mean, it is fine. It is fine, but if they're complicated, then they definitely need to come in the inpatient. So that's why in the inpatient, you are going to see huge loads of prescription on day one, and then we gradually bring them down. So we're looking at 160 milligrams of chlordiazepoxide on day one with an additional 80 milligrams, so a massive amount, and then we gradually bring them down from that dose. So the chances of complication like seizures and all are high during that time. But yes, it's a GABAergic drug, and I use a GABAergic medication like benzodiazepine to bring them from the substance. Yeah. This is a concept that you need to understand. So if it's playing on a particular neurotransmitter or a receptor, when you are withdrawing someone off the substance, you want something like a substitute. Yeah. And this is typically referred to as oral substitution treatment, something that I used to work in the project in South Asia called oral substitution program. And it was for HIV and AIDS for patients who are injecting opioids. So the substitute for heroin was methadone or buprenorphine because they work on the similar receptor. So the important thing is they need to work on the same receptors, but they should be longer lasting. Remember when I started, I was mentioning to you that there should be intoxication, but also a time when they come off that intoxication. So that time gap is required. If the time gap is longer, you won't have as much of a high. So you generally, when I've asked, I mean, obviously people in Liverpool, they use, or other places as well, use methadone to get a high. And I don't understand how they can get a high, but they do get a high. But heroin gives you a much bigger high because it's short acting. So short acting substances give a better, what you call as the intoxicant effect, just because it's so short acting that it kicks that dopamine rewards, fires it up so much that they go back to seek that. If there's some substance that works for a more longer or has a T-life, half-life of a longer period, they won't get as much intoxicant effect. Okay, so methadone can then be used for heroin, and chlordiazepoxide can therefore be used for alcohol. So do you see that concept of time lag between the substance, consuming the substance, and the T-life or the half-life of that substance is very important to then class it as a substance of abuse. Could Librium be abused? Yes, it can be abused, but I mean the percentage of people abused on Librium is much lesser. Similarly, people addicted to methadone is much lesser. Okay, so replacement, oral substitution or replacement, the concept is use a substance that works on the same receptor. Okay. Relapse prevention is basically that last stage of change where you want to maintain the person and prevent the relapse. Okay, so in alcohol, obviously there's loads of psychological work, and one of the common one which you might have heard is Alcohol Anonymous, and there's a small slide about Alcohol Anonymous. I won't cover it. So those are psychological work, and there's a lot of previous alcoholics. They tend to have set up group therapies and things like these are all motivation based group therapies, and they're very useful. So that's psychological support. From a medical point of view, and that's something more relevant to you, are two medication. I haven't used disulfiram in UK. I have obviously prescribed it in other countries, but I think the risk of death with disulfiram is something that puts people off from prescribing it. But anyway, we'll cover that one. Acamprosate is something that we commonly use. Okay, acamprosate works on an NMDA receptor, and I wonder how it is now doing the relapse prevention or anti-craving effect by working on NMDA. But I mean, if you know NMDA, it's a sort of an inhibitor, and it also plays on the GABA, and probably there is some link between the two. We don't have a clear explanation on how acamprosate works, but acamprosate works by reducing craving. And I mean, even if someone's got cirrhosis, I have prescribed acamprosate for them when they finish their detoxification. So acamprosate is more commonly used. I don't know, in other places, substance misuse psychiatrists might be a bit more gutsy or have more service that can monitor patients and might try disulfiram. I mean, when I tried disulfiram with my patient group, I've had better success. I should say that. So anyway, but acamprosate is a medication working on NMDA receptors and can reduce craving. Disulfiram, on the other side, works on what is called as aversion therapy. Aversion, I mean, I don't know if my pronunciation is correct. It's spelled as Aversion. Aversion as in getting averted to that feeling of alcohol. And that's how you tend to, cause a reduction in the use of alcohol. So basically, disulfiram, it prevents alcohol from getting metabolized and results in an overload of formaldehyde in the body. And that is a nasty piece of chemical that can cause a range of different symptoms, including headaches and nausea and things like that. And therefore, a person does not want to try alcohol ever again. The risk is obviously it can be to any form of alcohol, including the alcohol that is used in food. So you've got to be extremely careful if someone is on disulfiram, not to, to mention to them, not even a drop of alcohol, because it can give rise to what is called as disulfiram reaction. And you might have heard of disulfiram reaction with medications, antibiotics like metronidazole and things like that. So that's the disulfiram type reaction. But yeah, so it basically overloads the system with formaldehyde, which gives a very nasty feeling of nausea and headaches, and in extreme cases can cause death. So that's your disulfiram. Remember, acamprosate and disulfiram does come in exams as well, so it's important to know these. And that's they are categorized under the bracket of relapse prevention. Okay. Unit of alcohol is another thing that they tend to ask. Okay, you need to know how to calculate the units of alcohol. Basically, the total volume of the drink in ml, and then you multiply that with the percentage of alcohol in that drink, and then divide it by 1,000. So if there is a strong lager, 5.2%, and you've got a pint of it, which is 568, you divide it by 1,000, you get 2.95 units. I mean, it's easy for people because now all alcohol beverages have a marking of how many units are there. In a bottle, a liter bottle of spirits like whiskey, which has 40%, by the time we finish, just calculate that. I want to know the answer. So you've got a liter bottle of whiskey, which is 40%. So we need to know how much units are there. Let me know, okay, if you get a chance by the time I finish through these slides. Okay, I'll leave this alcohol anonymous bit for you to look at. Alcohol-related emergency, we spoke about DT, which is 48 hours after abstinence. You can have confusion, hallucinations, agitation, sweating, tremors, and seizures. Treatment is obviously reducing regime of benzodiazepine. And don't forget, at that stage, you want to try parenteral thiamine rather than just oral. Okay, I mean, I would actually make it a part of the treatment protocol. So anyway, and any patient that comes, I want to give them at least 2 or 3 doses of Pebrinex, which is the parenteral vitamin B1, to prevent obviously Wernicke's and Korsakoff syndrome, and it is preventable. And therefore, I want to make the best of the opportunity. So when the patient comes in addition to the benzodiazepine regime, I will always prescribe them at least 3 doses of parenteral, if not 5. Okay, so that's the start of the treatment in the first 5 days. Yeah. Okay. Wernicke's encephalopathy is a classical triad of confusion, ataxia, and ophthalmoplegia. Unfortunately, I've been in this specialty for so long, and I've not seen this classical triad. But for exams, obviously, they keep asking you. So confusion will be there if you're withdrawing from alcohol. Ataxia will be there. Yes, it can be there. But ataxia with ophthalmoplegia, if you see it together, maybe that might be your indicator that is Wernicke's encephalopathy. Do you see it? Yes, you can see it, and it's very common. Yeah, so I mean, I'm just going by the assumption. Yes, every patient that comes with that heavy dose of alcohol, I'm going to start treating them as if they're going to have Wernicke's encephalopathy, and the treatment is obviously B1. Yeah, if untreated, obviously that's the worry, isn't it? Irreversible anterograde amnesia with confabulation. I've seen only 2 cases, okay, in the past several years of working with people with alcohol dependence. Yeah. And I'm not sure whether that's only alcohol. Could there be other things? Because as you might imagine, many of them have had falls and brain injury related, that's something which I obviously do now as my job in neuropsychiatry. You can't differentiate whether it was all alcohol related. So, but yes, I have seen patients with anterograde amnesia and then filling up the gaps with confabulation, as in false memory. And there's an aspect to them where they tend to have attach it with humor. And then therefore, in a someone who's not experienced in assessing a patient with dementia and Korsakoff psychosis might feel that this is a normal conversation, but it's actually confabulation because they've added so much humor to that. It becomes a pleasant consultation, but you don't realize that it was actually covering up the amnesia. So that's your Korsakoff psychosis. Irreversible, remember, you cannot reverse it once it reaches that point. And I think the reason why I haven't seen as many Korsakoff psychosis is because we become so good at treating alcohol withdrawal. So we tend to use thiamine in and out. It's become so cheap that anyone and everyone will be prescribed that if they have been diagnosed with dependence of alcohol. Okay. Benzodiazepine, almost because it's like GABA, it will have a similar presentation like alcohol, and therefore can cause all the trouble that alcohol will cause. Okay, but I mean, do we see cases of heavy benzodiazepine use? We do see, but it's mostly in association with other substance. So poly substance misuse is very common rather than mono substance misuse. Okay, the only mono substance misuse generally is alcohol. Okay, that people can be only addicted to alcohol, but I mean, even with alcohol, many people are addicted to nicotine. So I mean, the pure one mono substance use is not usually found in your clinic of substance misuse. Okay, so benzodiazepine is very common in people who use opioids as well as people who use cocaine. Okay, I'm almost running out of time. So what I'm going to do is just leaving this for you to go through. So cocaine, yeah. Cocaine is a stimulant, remember, we'll cover that later. You see that it's available as a powder and can be available as a crack or and an alkaloid, okay, which you need to heat it and then use a pipe to inhale that. Okay, you can inject it. When it's injected with the help of vitamin C, often with heroin, it's called speedballing. So you get both the effects of heroin as well as cocaine, which is a stimulant. Okay, cannabis, yeah, popular, very popular. Yeah, conjunctival injection is basically if you see someone who's intoxicated on cannabis, they'll have red eyes. Basically, the conjunctiva will be completely red. So that's the word, conjunctival injection. In dry mouth is common. Obviously, euphoria is there. There's an element of euphoria, and sometimes they say that it can lead to a bad trip, which means not everybody enjoys that. You need to have an atmosphere to enjoy that. That's what they tend to say. So, but obviously, chronic users don't look at those things. But yeah, it has that ability to change your experience, and you can have what is called as a bad trip with cannabis, which is another word used in addiction with LSD as well, where you can have what is called as a bad trip. These are all there covered in this. Okay, so heroin, yeah. You inject it, obviously, as I mentioned, speedballing, yeah, but you can smoke it by heating on a tin foil, yeah, and it's called chasing the dragon, yeah. Pinpoint pupils, I mentioned, isn't it? So you can see classically pinpoint pupils when someone is intoxicated, and then it's dilated when you're withdrawing. Yeah, there you go. Pinpoint pupils, track marks, yeah, poor nutrition, obviously, because of salience. Remember salience, one of the criteria in dependence. So it loses the interest in food, loses the interest in their care, physical care. So you find a completely disheveled person. And obviously blood-borne viruses. And that's the reason why my work with the UN was closely funded from HIV and AIDS project as well, because there's a huge risk of HIV AIDS because of needle sharing. Obviously, over here we've been quite careful, and obviously in one of the aspect of the treatment was to provide them with needles rather than just, and that's the concept of harm reduction, isn't it? You know there's going to be harm, provide them with that support, give them those syringes. I mean, you're not going to stop them, and at least prevent the harm like HIV and obviously other complications. So that's your harm reduction. Yeah, that's the harm reduction, needle exchange. Encourage smoke rather than inject, raise awareness of overdose. So these are some of the things that you could do. And then the OST, oral substitution, which I already covered, methadone, full agonist, yeah, while buprenorphine is partial agonist, yeah. Buprenorphine can be injected. So sometimes you read that word Subutex will be called Suboxone because it is clubbed with a antagonist, which is naloxone. So buprenorphine plus naloxone is sometimes available as Suboxone, and is prescribed for someone who could be a risk of injecting the buprenorphine you supply from your clinic. Yeah, so if you suspect somebody could be injecting buprenorphine, always prescribe them Suboxone rather than Subotex, okay? Because it's a partial agonist. Okay, so, okay, I'll leave this for you to read. So amphetamines, ecstasy, ketamine, LSD, and novel psychoactive substances. Okay, I'm going to leave all that for you, but I'm going to just touch this one, which is very important. How do you differentiate psychoactive substance? I generally use the terminology on one side called stimulants and the other side as downers. And I think that basically will give you a sort of bracket in which you can club various substances that might be there currently or even in your future practice, because substances keep developing and you'll get new substance. But generally a person uses it either as a stimulant or a downer. Sometimes use a stimulant, and to bring themselves down, they'll use a downer. So sedatives are downers, alcohol is a downer, okay? Now, the third category is a hallucinogen, and I put synthetic cannabinoids or cannabinoids in general between downers and hallucinogens. Remember, cannabis causes that, effect of relaxation. So that is very close to a downer effect, but it can also result in a, sort of perceptual disturbances and, hallucinatory type of experience, which is common with LSD. So I've put them in between, but generally these are the different categories that I would usually categorize the psychoactive substance. This helps us to identify the intoxication effects and therefore the withdrawal effects, okay, and helps you clinically as well to differentiate. And then you can send a toxicology to understand which is the one. Yeah. I'll leave this again for you to look at, and then the classification. Okay, let me take questions. How do I do that? Do I just take this off now? Hello?
Hello, yeah, there's a chat in the bottom of the screen. I don't know if you can see that there.
Do I have to exit this? Do I have to exit the sharing button?
You might be able to keep that on. If you go back to whatever screen your Zoom's on.
Yeah, I've got 7. So, chat.
Are there any questions on there for Dr. DaCosta?
Do you want to unmute and ask? I'm trying to get the chat.
I think all we've got on there is clarification about.
Okay. Yes, I've got here. So yeah.
There's a question there.
Was it Othello syndrome? So you're right, Priya, you're absolutely right. It's Othello syndrome. That's the morbid jealousy. Okay, it happens with alcohol use. Yeah, can happen with benzodiazepine as well, but I've never seen. It's mostly the cases I've seen has been. It's called Othello's is because it's classical story from, is it Shakespeare's Othello's? So where the person becomes jealous about his partner and then kills the partner. I think a liter of, yeah, that's correct. Yeah, a liter of 40% would be 40 units. That's correct. Yeah. Where do you, okay, I'm not sure. I'm going to give the slides. You can use them because there's a lot of information, particularly the dual diagnosis bit. I have a little bit of information down as well to help you with the percentages and the links as well. Okay, just follow those links. This is something we use for MRC Psych, and it's something that we have agreed as a standard, okay, if they ask you for exams. So stay with that, okay. Are there many other antidotes for substance overdoses beyond those for alcohol and opioids?
Yes, antidotes are there, isn't it? I'm not talking about just substances, but toxins in general, isn't it? So if you're looking at um, uh, any toxin, there'll be some or the other antidotes, isn't it? So you're basically looking at an antagonist, isn't it? For example, someone who's got pinpoint pupils and not breathing properly, you would give naloxone because naloxone is an antagonist to the opioid receptor. Yeah, so yes, I think the only classical one is obviously naloxone, which I'm aware from a substance misuse side. Okay. Is there any prophylaxis for delirium tremens for a patient admitted to hospital? Is prophylaxis as in preventing delirium tremens? Interesting question. Can we prevent? Yeah, preventing obviously substances. Prophylaxis, early thiamine administration, yes, probably, yeah. Early signs of withdrawal, yes, probably. But I mean, obviously, the ones which we get are the ones who have never been in pre-contemplation, isn't it? And that might be the only chance that we might have to bring them into contemplation and action phase. So yeah, you could do prophylaxis, early on treatment, starting thiamine, psychoeducating them, getting them involved with different psychological groups. Could you use medication to reduce somebody's increase, like some people come and say that, my partner or someone is using heavily, can we stop him from drinking? I'm not sure whether you can actually change somebody's behavior if they're not motivated to do. Although I know some of my colleagues in gastroenterology in Liverpool, Royal, have been trying different medication. I'm not sure. I don't have the research evidence, so I can't say. So they use um, different things like naltrexone can be used. Definitely, naltrexone is a long-acting opioid antagonist and is known to show some anti-craving effects. Could we prescribe acamprosate? I would still prescribe acamprosate if they're not using very heavy amount of alcohol. There's one more, I can't remember it, but obviously they won't ask that because there's no much research, but something that, some of the other colleagues in, gastroenterology and hepatology are using for some of their patients. But I mean, I did one study on topiramate, which is an anti-epileptic, whether it could be used. But again, all these medications are metabolized in the liver, and you're already giving someone who's using high level of alcohol. Are you causing more harm rather than harm reduction? So, I mean, that's something that you should. So yes, prophylaxis, there's lots of things, isn't it? Medical as well as non-medical.